to briefly introduce our speakers for today's session. We have 4 folks who will be sharing their knowledge with us today. Dr. Bernie Pauly is a professor in the School of Nursing, a scientist with the Canadian Institute for Substance Use Research, and a University of Victoria Community Engaged Scholar. Her research focuses on the promotion of health equity at the intersection of substance use and homelessness in collaboration with communities impacted by health inequities. Her research has informed provincial, regional, and national harm reduction policies in nursing, housing, and healthcare, including national operational guidance for managed alcohol programs. Currently, she is the co-lead of the Canadian Managed Alcohol Program Study, BC Provincial Evaluation of Safer Supply, BC Community Laboratory on Substance Use, the Many Ways of Doing the Same Thing project, and the Housing Justice Project. She is a fellow of the Canadian Academy of Nursing and Canadian Academy of Health Sciences, and an international collaborator with Salvation Army Centre for Addiction Services and Research at the University of Stirling and the Australian MAP Protocol Steering Committee. Next, we have Dr. Tim Stockwell, the former director of the Canadian Institute for Substance Use Research. He was our director from 2004 until 2020. He led Australia's National Drug Research Institute as deputy director and then director for 16 years. Tim's research interests in alcohol policy include measurement and modeling of alcohol consumption and related harms, and assessing the impacts of pricing and taxation policies such as minimum prices. Tim is a fellow of the Royal Society of Canada, and he is also the co-lead of the Canadian Managed Alcohol Program Study, CMAPS. And Aaron Bailey is a program coordinator with the Eastside Illicit Drinkers Group for Education at the Vancouver Area Network of Drug Users, and research assistant with the Canadian Managed Alcohol Program Study here at UVic. He also holds a Master of Science in Health Promotion and supports the daily operation of VANDU's overdose prevention site. Aaron's academic work explores the relationship between alcohol policy history, dispossession, and present-day community organizing in Vancouver's downtown East Side. And Herb Varley is a Niska and Nuu-chah-nulth activist and longtime resident of the downtown East Side. Herb is a current member of the Eastside Illicit Drinkers Group for Education Steering Committee, a community leader at PHS Drinkers Lounge Community Managed Alcohol Program, and a member of the Holding Space Project team at the University of Victoria. And now I will hand things over to Dr. Bernie Pauly to get us started.
Hi, everyone. I'm really happy to be doing this MAPS 101. And a question that's kind of been driving our program of research for many years is, can giving alcohol be a harm reduction intervention? And I've been co-leading the Canadian Managed Alcohol Program Study with Tim for over a decade, and for over a decade working in collaboration with the Eastside Illicit Drinkers for Education, who've been instrumental to the conduct and outputs of this research. We have a really large study team, and I just want to acknowledge all of the researchers, collaborators, and knowledge users that have worked with us for over a decade. I also want to acknowledge that I am a settler on the traditional territories of the Lekwungen speaking people, and recognize that our research takes place on many different First Nations territories across this country, and the disproportionate impact of colonialism on Indigenous people and propelling the harms of alcohol. We've been very fortunate over a decade to be funded by numerous different funders, and the views that we present in this research are that of the research team and not of the funders. Because we're really fortunate to be here with CAPE, I know that you are extremely familiar with the harms and costs of alcohol, that while illicit substance is still a costly and intoxicating carcinogen. And you'll see this, you'll be very familiar with this CISUR info. And I'm going to try to go to the next slide in there we go. I think it's important to put into place, where do managed alcohol programs fit within the context of alcohol policy? And again, I know that many of you are very familiar with alcohol policy and the way in which it works to reduce harms through pricing, where it's sold, through drinking and driving, marketing and advertising, minimum legal drinking ages, screening and brief intervention, server training and management. So all of those are important population level strategies. But we have a group of people who often are left out of those policies and the protections that are provided to the whole population. And so often people at the intersection of homelessness and heavy drinking may be drinking unsafe sources of alcohol, such as non-beverage alcohol, which is often criminalized and stigmatized, even though they're consuming a legal substance. Unsafe patterns of drinking, such as binge drinking or forced withdrawals, and drinking in unsafe settings. And many managed alcohol programs have often come into being because of the harms of assaults, violence, and injury, exposure, and death that individuals are exposed to when they don't have a safe place to drink. Because although, again, alcohol is a legal substance, if you don't have a home or you don't have access to a pub, there are increased harms of drinking outdoors. So as a response, in Canada particularly, a response was to develop managed alcohol programs. And if you want to learn and a bit more about some of the history, I encourage you to watch The Pour, which was done by the Fifth Estate a number of years ago, that highlights, whoops, flipped ahead on me, that highlights the Ottawa Managed Alcohol Program, which was one of the very early programs. The only earlier one was a program in Toronto, which was started to prevent freezing deaths of individuals who were drinking outdoors. What you see in the photo is actually a picture at Ottawa. The Guardian did a super good article on the program and the research, but they gave it an extremely bad title. That title of Shelter Gives Wine to Alcoholics does not reflect really what happens in a managed alcohol program. And I'm going to just speak briefly about that. So early on, when we started the research, we looked at the different components of a managed alcohol program, and providing a safer supply as an alternative to non-beverage alcohol and safer amounts that smooth out drinking is part of a managed alcohol program, but there's much more to that, including the provision of a safer place to be, although there are programs that are drop-in programs, and I know we're going to hear more about those later, but also often providing people with access to health services, which they haven't had connection to, social services, and importantly, social spaces for drinking and for maintaining and building relationships of social support and the provision of cultural events. So as I mentioned, in Canada, we have actually had managed alcohol programs for quite a long time. The first one was in Toronto at Seton House. And it was, as I said, in response to, it was actually mandated through an inquest into the freezing deaths of three men because they couldn't come into the shelter if they had their alcohol, so they stayed outside. We had programs across the country, as you can see here. The ones with the stars are ones that we've worked with to conduct some of the evaluations, 7 programs in 6 different cities. And since COVID, we've had an explosion in the number of programs. Pre-COVID, we had about 23 programs across Canada. We now have more than 40 managed alcohol programs in Canada. There are also programs internationally in Scotland and other parts of the UK. There are some in the United States and one that is emerging in Australia. So just to give you an idea of the eligibility for the program, it typically is people with high levels of drinking, maybe drinking non-beverage. ongoing chronic homelessness. They're not able to be housed because of drinking, and that's really how we started some of this research, was recognition that we needed a program that would be supportive to people. Frequent public intoxication, sometimes multiple failed attempts at abstinence, and frequent use of police and health services. Those aren't all required, but they do occur. So before I turn it over to Tim, just briefly, the purpose of so these programs have been operating, our research has come alongside it. And the purpose of the research is to rigorously evaluate MAPS in Canada and generate insights into implementation. And you can see there are key research questions which focuses on do they reduce consumption, alcohol-related harms, improve quality, housing tenure, health and quality of life, and economic costs? And if they do, how? And we're going to answer some of those questions. Lastly, and importantly, this research has been a collaboration with EIDGE since the beginning. This is one of our very first team meetings, and you can see Brittany Graham, and I'm not sure if I can locate, there was an EIDGE member there named Ron as well. And we've also collaborated with people across the country who run and operate managed alcohol programs. So I'm going to turn it over to Tim for some of the quantitative findings, and then I'll do some qualitative, and then Herb and Aaron are going to take it over.
Thank you, Bernie. Good morning, good afternoon. I'm going to try and condense 4 research papers that took us about 14 years to put together, with all the work that's that Bernie's been outlining, and try and put that into about 15 minutes. So we've got this mixed methods approach to studying multiple sites where managed alcohol programs have been operating across 6 cities. That's expanded in some other studies, but the 4 papers I will talk about included roughly 175 participants of MAP programs, nearly 200 people who are similar neighborhood controls who had shared issues with alcohol and homelessness. So we've got quantitative data, which I'll talk about in the next few minutes, taken as people enter programs and at various follow-up points. We also look at how they fare in the hospital or police systems, if there's records of contacts with emergency rooms, hospitals, and if people die. There's the qualitative interviews, and we've also done descriptive analyses of protocols that have used and policies that have been applied on the programs themselves. So, and you can find all of this in published papers, which we're happy to provide, and you can find on our website. Now, am I going to be able to move this forward? Help. Oh, here we are. Yes, it works. Thank goodness for that. Outcomes. So, with the 3 main areas of harm to be concerned about, and it poses a kind of a sharp dilemma, because of course we have acute problems which MAPS are really well placed to address. I mean, the freezing deaths are the most tragic example, but the injuries, poisonings, various kinds of acute illness, and of course then there's the longer term chronic conditions that anyone is at risk of if they drink heavily. So liver disease, cancers, strokes, gastrointestinal diseases, and of course the multiple social problems that accompany troubled relationships with alcohol. So really one of the issues we've grappled is how did one trade off acute harms versus the chronic harms. So we have to bear in mind there's often it's urgent to deal with the acute, but we mustn't forget the longer term chronic issues as well. Let's click on the right place, move forward. We've had a lot of challenges doing this work, but we're grateful to have been given the chance to address them. Each site can have small numbers, and it's kind of hard to generalize. There's very low turnover, which is a good thing, of course, for the programs, because the participants tend to really get engaged and benefit, it appears. So this limits the number of people for research purposes. There's multiple sites with diverse policies, and we've had to deal with dozens and dozens and dozens of ethics and privacy clearances, which are all necessary, but incredibly time consuming. In terms of the measures, there's issues about underreporting of alcohol use, particularly or potentially outside alcohol, although we have found in the confidential research interviews, people are fairly forthcoming and willing to share, and of course they are kept confidential. Moving on. Very briefly, we had a pilot study. It's written up in the reference you can see there, the Waikiki Wind Centre in Thunder Bay. All participants were Indigenous, both men and women. They had transitional housing, and we had 20 match controls, and we followed up to 6 months, kind of very quickly through the results. The wonderful thing is they all retained the housing, all the 18 participants, whereas all the controls remained homeless, which of course was sad. But it illustrates the benefits. There were reductions of non-beverage alcohol use. For those that we had data, there appeared to be actually improvements in liver functioning for the people attending the managed alcohol program, and their patterns of alcohol use smoothed out. So drinking on more days, but fewer drinks per day, and less extreme intoxication and related harms. Examples were less police contacts, less time in custody, fewer hospital admissions, and admissions to detox, compared with controls over that 6-month period. And we did a cost-benefit analysis, just to say for every dollar invested, because of all those reductions in the use of health and police services, the savings were greater than the cost that was needed to run the programs. And this is kind of, I hope you can get your head around this. This is one of our first quantitative studies with a whole sample, with across the 5 or 6 cities and 7 sites. And it shows the number of days people were drinking per month, and how many drinks they had on average per day, and how much non-beverage NBA, how much non-beverage alcohol was going on. And these are very large numbers. So the people who actually had been on managed alcohol programs longer term, more than a few months, were pretty much drinking every single day, but drinking significantly fewer drinks per day, 15. That's still an awful lot of alcohol, but it was significantly less than those who just entered the program or the controls. And there was significantly less non-beverage alcohol use. And so that's all I'll say about that. That was our second paper. I'm going to talk about the two papers which I think were the strongest. They used like a longitudinal analysis. First one we called the trajectories study, where we looked at how alcohol use and related harms played out over 12 months from baseline to follow-ups. We had a very strong follow-up rate. And then the second study looked at data linkage. We looked at the death, emergency room, and hospital stays for managed alcohol program clients over an 11-year period compared with controls. So pretty strong design. The characteristics of our samples, 80% male, average age 46, many Indigenous participants. Pretty much everyone showed signs of what we'd call severe alcohol dependence. And the distribution across the 5 cities between the controls and the participants was very similar. So we had good controls, similar people in each city to compare the trends with, and levels of harm and non-beverage alcohol consumption at the beginning of the entry to managed alcohol program. You know, I'm just going to go to the next slide just to keep things moving. The summary of the results for that 12-month follow-up. Again, MAP participants had smoother patterns of drinking with similar overall volume, but just drunk more smoothly, more days, fewer drinks per day. MAP participants reported fewer harms overall than controls, but unfortunately our baseline occurred several weeks into the program. It appeared many of the benefits occurred quickly, and so the controls actually significantly reduced their harms, which is something that often happens, but still at follow-up the MAP participants had lower levels of alcohol-related harm. The participants again kept their housing, nearly all of them, and they drank less non-beverage alcohol. Another finding was that the sites that had fairly strict policies about outside drinking had better outcomes in relation to reducing consumption and harm. So the third study, which we looked at deaths, emergency room visits, and hospitalizations or hospital days, we measured that. This gives you the idea of the strength of the data set. The controls, we had 128 people we were able to follow up through the system with their permission, of course, covering over 500,000 days across those people. For people on the managed alcohol programs, similar number of people, but they had between them about 580 stays, or exactly 580 stays, and nearly 200,000 days experienced, and 481 periods outside the program, and nearly 140,000 days to observe. And okay, a pretty harsh bottom line, rates of death, people sadly did die, many, there were quite a number of deaths among the controls and people on the program. But look, the key thing is here, these are 0.52 is the risk. That means the risk for people on the managed alcohol program of dying during those observation periods was about half what it was for the controls. And when they were off the managed alcohol program, it was significantly higher. So there was a protective effect. People on the program were much less likely to die. In terms of emergency room presentations, it's a similar picture. There's no overall significant difference between the controls and people on MAP, but a big difference before MAP and after MAP. So the managed alcohol program participants were significantly more likely to visit the ER when they were not on a MAP. The MAPs appeared to protect against this outcome. Perhaps our strongest data was just look at the number of days spent in hospital. So the controls on average were spending about twice as much time in hospital in a given year than people participating in the managed alcohol programs. So a few conclusions. I think it's important to emphasize a lot of people fear that managed alcohol program participants are going to kill people. We're giving a lot of alcohol to a very vulnerable group of people, but we didn't see this. Compared with controls, there's a 48% reduction. There is a high mortality rate in this population, but people on managed alcohol programs are receiving some protection. There was a change in pattern of emergency room presentations, actually more alcohol-related ones and fewer non-alcohol-related emergency room presentations. MAP participants spent significantly less time in hospital than controls, and the MAPs appeared to increase life expectancy and improve health outcomes compared with controls. So just a few notes before I wind up, little cautious thoughts. We have to be mindful of the tragic chronic effects of the life-shortening effects of heavy alcohol use. There is the idea that we mustn't buy into that beverage alcohol is somehow safe. Non-beverage alcohol is clearly terribly dangerous and toxic, but one of the main risks of non-beverage alcohol is it enables people to drink a lot of ethanol in high doses and high concentrations at very low price. And so it's still the same substance that's causing harm. One way of balancing all the different harms, the acute versus the chronic, is to really think hard about having high threshold criteria for, it's not just everyone with a mild problem that it would be appropriate to enter a MAP and receive high levels of alcohol each day. They're fostering peer-led restrictions on outside drinking. A lot of the motive for minimizing outside drinking we've observed does come from the participants themselves, and they can help, support that value that not undermining the program by adding a lot of outside drinking. Offering support from participants who wish to actually reduce or stop use is clearly very important. And monitoring physical health, for example, liver function, and providing feedback to the participants so they can make informed decisions about continuing to participate or not. And a final thought, these are data on cannabis use, comparing MAPS and controls. And the point of this slide is to say, over a lifetime, there's no difference. There's about 90% of the participants' controls report past cannabis use. But over the past 12 months or past 30 days, significantly more controls, the MAPS, are using cannabis. Now, a key idea here is that cannabis is very likely safer than alcohol. So we have to be mindful that if we don't provide cannabis alongside the alcohol, we could be increasing harm because we're encouraging more consumption of alcohol relative to cannabis. And so this is why we're at the moment looking at working with sites to look at the potential benefits of substituting, wherever possible, cannabis for alcohol. And I'll pass it back to Bernie now.
Thanks, Tim. I'm going to speak just briefly to some of the implementation findings, because you've seen from Tim some of the really important outcomes in terms of reducing harms, mortality, and healthcare usage. I think we also need to understand how programs work. And I think what I want to share just before I start the implementation is a quote from one of the participants who really captured what a lot of people said about the impact of the program for them. That it was an opportunity of connecting with family, a place of home and hope. This program has given me hope and has allowed me to really think what I want to do with the rest of my life, because I was not stuck. I guess you could say rock bottom, and going home couldn't get me out of that rock bottom I was in. But since coming here, I know there's a horizon waiting for me, and really capturing that aspect of hope for the future. So how do MAPS work? We did what's called a situational analysis, where we mapped where individuals were in the community who met the criteria for managed alcohol. And what they were doing is they were cycling through all these different arenas. They might be in hospital, they might be in a jail, they might be in a shelter or a housing, they might be out in the community, on the street, staying with someone else. But overridingly, it was a story of displacement, survival, and disconnection for people in a form of street-based survival. And in some of the work we've done with EIDGE and other groups, they've identified that, there's also a pattern of survival drinking, which is why we see some of the changes. So when a MAP is introduced into the community, it often introduces a service or a program that wasn't there before, that focuses on reducing harms. And it disrupts this cycle of survival drinking. And people are no longer cycling through these environments, and they're describing, coming into the MAP, a greater sense of safety, security, connection to self and community. And the really thing I want to say is that in that cycle, when people are cycling around before they get into a MAP, they are in a lot of services and they are not getting the services that they need. And that is dramatically shifted when they enter into a MAP, because a MAP also provides connection to health and social service, as well as social and cultural connections. Just briefly, I want to mention that this was a paper that we did, that Tim and Rebecca, a grad student, led, around the fact that when people are in a MAP, they're less likely to rebudget for essentials, use illicit drugs, steal, or commit property theft. So this has some really important impacts. So we looked across programs and we said, what have we learned about implementation? And some really important things. The type of program has to match the needs of the people who are accessing it and the supports. And I know Herb and Aaron are going to talk a bit about the Drinkers Lounge, which is really a program designed by peers for peers that I think exemplifies this kind of principle. And I think other programs have looked at the services that they provide to make sure they're matching the needs of the people who are accessing it. Obviously, alcohol administration and dosing policies so that alcohol is not additive, but rather it is doing the work of reducing harms. Housing is essential. We've looked at programs where housing was not available nearby or not available as part of the program, and the housing significantly reduces the harms. In spite of that, programs where there's community connectedness and belonging also tend to have some of the best outcomes. That social connection and social support is a really critical piece. Based on the research that we've done through CMAPS over more than a decade, we were able to partner with the British Columbia Centre for Substance Use, along with EIDGE, and created the first that I know of operational guidance for managed alcohol programs for Canada, and it's readily available online. It summarizes the research as well as a lot of direction about how managed alcohol programs can be implemented. I want to just finish with two really important future directions. As we've been working with CMAPS, we've been approached many times by Indigenous communities to say, what would it mean to operate an Indigenous-led, Indigenous-formed MAP? And this is a report that we partnered with Ambrose Place in Edmonton, and you can see the title of the report is in English as well as the 5 Indigenous languages of the region, and the importance of placing a map within a cultural framework and context. And that's we've been working with since that time, Aboriginal Coalition to End Homelessness here in Victoria, and can point you in the direction of some of our work there. And then Tim mentioned this important finding around cannabis and the potential for cannabis as a harm reduction tool for people in the MAP. It has not only is it less harms, but it also has some benefits in terms of managing withdrawal, in terms of pain, appetite, sleep, potential for people as a substitution for alcohol. We did an initial feasibility study of this back in 2021 with some funding from CISUR, and have started and will hopefully soon be able to share with you some of the findings from an observational study of MAP and cannabis. And you can find everything we've talked about on CMAPS, www.cmaps.ca. And if you're interested in MAPS, we're very fortunate to have Aaron and Brittany Graham, who helped to facilitate the OG of community of practices in the alcohol world. That's our MAP community of practice. And with that, I'm going to turn it over to Aaron and Herb.
Mm-hmm. Thank you very much, Bernie and Tim, for those fantastic presentations. Everybody, my name is Aaron Bailey. I'm the current program coordinator here with EIDGE, which is the Eastside Illicit Drinkers Group for Education at VANDU. We are currently calling in from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. Just before I turn it over to Herb here, I say that please pardon my speech impediment. It sometimes gets in the way, sometimes it doesn't. We have to see what kind of day today is.
So to add on to the territorial acknowledgement that several people have done today, but sometimes I do 5 meetings a day and I get tired of doing it. So I don't do it all the time, and it upsets some people. But language is important. That's whenever I talk about I always say so-called Canada. so-called Vancouver, so-called Edmonton, etc., etc. One of the things that people often forget is one of the most powerful languages, or one of the most powerful weapons that the colonizers had, was their cartographers and their botanists and their biologists, their so-called scientists. And by renaming rivers, mountains ad infinitum, they're literally erasing 10,000 years at least of indigenous knowledges. To add on to what a couple of people had said, finding community, like I had to come to terms with myself. Like, I'm gonna drink every day. Being on a map has helped me drink less. Sometimes I go a little bit harder than I meant to. But just finding a community that's like, hey, we like to drink every day. So that's what we're gonna do. And I recently had a hospital visit, but that was more related to losing a dear friend of 32 years. So that was kind of an aberration. But the best way I could describe EDGE is and the Drinkers Lounge, is that we're a community of drinkers that tries to keep drinkers as safe as possible.
Yeah, not much to add to that. Yeah, thank you, Herb. So as Herb said, EDGE is the VANDU subgroup for folks that are current or former illicit drinkers. So EDGE defines illicit drinking as current or former non-beverage alcohol use, so hand sanitizer, cooking wine, mouthwash, etc., or folks that drink in a way that is criminalized. So for EDGE members, that latter category typically involves folks that are currently unhoused or who live in single room occupancy hotels, which lack amenities and common spaces by coercing folks into public space. EDGE came to be back in 2011 in response to a caravan around BC by VANDU members of Vancouver's drug user group. And this kind of general sentiment that within the harm reduction movement in general, and within the health services sector, that folks that use alcohol, and specifically non-beverage drinkers, were being left behind, and that they're experiencing extremely high mortality, a very high morbidity for that reason. EDGE's mandate is to include drinkers in the discussion and design of the policies and programs that are meant to serve them. And we do this with the drug user unionist model that VANDU employs. So do and share tons of research, and so it's through the partnership with the CMAPS study. As Bernie mentioned earlier too, we work to address inequities and to strike a balance between street level harm reductionist alcohol policy and the evidence-based population level controls that do reduce harms for most folks, for most of the population. For the population of EDGE, however, restrictions on availability, price increases, etc., can coerce folks into non-beverage use and thereby increase harms. Pardon me.
Yeah, and EDGE did play a big part in fighting Bill C-31, 34, which basically in so-called BC made it the only place you could use it was like in the middle of the street. Because I don't know what it's called in Canada, But as drinkers, we know prohibition doesn't work. I know in the States it was called the Volstead Act. And during the Volstead Act, people were going blind, they were dying because they're drinking ethanol. There were more car accidents, you know. So we were heavily cited in the injunction against that. Now the so-called BC government is trying to go over our heads and trying to go to the feds. Which is kind of a compliment actually, because that means we made a formidable argument that they're not ready to counter. But also at EDGE, we've been trying to, well, we started living on the EDGE, we should send them all a PDF.
Absolutely.
We started a publication called Living on the Edge where we talk about our policies. We have a page in memoriam for the people that we've lost during the drug war. And we have a nutritional guide. George isn't here today, he's running a barbecue. But we have a nutritional guide for what heavy drinkers are often lacking.
I was gonna get to that. That's got a full slide too.
Okay.
So speak a bit more about what the nature of the relationship between EDGE and CMAPS is. So what we really want to underscore here is that the partnership between both groups has been baked into the research project since its inception and has consistently been one of mutual support and mutual benefit, and that improves the quality of CMAPS data and also supports EDGE to advance our own advocacy goals too. So this mutual support began back in 2013. So as CMAPS began its work to evaluate what was a now defunct map in Vancouver's downtown east side, EDGE was present as these local peer experts. Since that kind of initial work together, really that partnership's that's become permanent and not ad hoc tokenistic consultation. So by doing so, CMAPS has empowered each different iteration of the democratically elected EDGE membership to become trained research advisors and not select individuals. This has meant that EDGE gets to help guide work on study design, research recruitment. Its members get to participate to share their own stories, guide CMAPS to guide CMAPS advocacy, and to validate CMAPS findings. So this adds rigor to CMAPS data, also advancing EDGE's strategic interests as well. And this allows us to make sure that the research questions are relevant, ethical, and reflect membership priorities. And the cannabis case study that we're just about to get to is a very nice and clear-cut example of that. So EDGE and CMAPS also work together a lot doing community facing knowledge translation. So how do we bring together these sort of academic and clinical knowledges with the lived experience of the EDGE membership, with MAP clients, with street-based illicit drinkers too, and so to ensure that evidence-based alcohol harm reduction information is accessible. And it had to describe sort of what the nature of this partnership is in one term. I would just say it is being in the loop at all times. So EDGE is consistently at the table with CMAPS. We understand what the project has done and sort of involved with active data collection, and get to, among other partners, advise what the future directions of CMAPS are. And so this is an example sort of what that's like in practice. So this is a gathering of MAP sites offering cannabis to their clients that the CMAP study convened last October. And the purpose of this gathering is to hear from sites that were, alongside with the CMAP study as an evaluator, hear from these different pilot sites about how voluntary cannabis substitution was going at their sites, what had worked, what hadn't, and most importantly, what the future directions of cannabis research ought to be. You can see on the left here, EIDGE is in the foreground there. That's Herb and John, members of the steering committee, actively contributing to that discussion, which, resulted in lots of great consensus about, in order for cannabis substitution to work at MAPS, our national cannabis policies need an equitable overhaul. Express concerns about cost. Folks got to express their concerns about the involvement of law enforcement in the private retail system, et cetera. So EIDGE sort of invited into the fold, as we have been since 2013. And with respect to that sort of community-facing knowledge translation, I love this example because I think this pandemic-specific safer drinking guidance is a really clear-cut example of sort of how CMAP's clinical knowledge interfaces with EIDGE's. For example, the standard drink applications here fall firmly in the realm of the CMAPS research team. I could not do these. This is not my expertise at all. CMAPS teams got the expertise to sort of do these conversions.
Is by asking the drinkers.
Right.
We know how to keep ourselves as safe as possible most of the time. Sometimes we slip, but that's the nature of addiction.
Right. Totally. So CMAPS, it's able to understand and to translate it's about national guidances with CCSA to sort of do these standard drink conversions. EIDGE members know, okay, what is being consumed as non-beverage alcohols to make that conversion relevant for the community? What does it mean to drink in a safe place in the context of the Downton East Side when green spaces are very rare and folks tend to live in SROs, for example? Thing is that, CMAPS advises on what is a safe, effective taper schedule, while EIDGE, adds the context about what that looks like in the community-based setting.
I've actually fallen behind on that. I was supposed to write a guide on giving your liver a break. I got to do that.
It's still to come, though. And so, one case study about the Cannabis project in particular, I think bears just chatting about quite briefly. So this date's not correct. The first MAP sites in Canada that began to do the cannabis substitution being evaluated by CMAPS, they started in 2022, 2023, if I'm not mistaken. But at the time, these sites weren't located in Vancouver. They were on Vancouver Island and in Ottawa, Ontario. Because the idea of offering voluntary cannabis substitution for MAP clients was so novel, very little guidance existed to support those programs to implement their pilots. Very little existed about, MAP relevant harm reduction information, guidance on use, advice, what dimensions would make a program relatively high quality for its participants. Luckily, though, EIDGE held decades and decades of combined knowledge of current MAP clients, former MAP clients, and illicit drinkers who are actively using cannabis independently as a effective harm reduction intervention for years. So this gap in the literature, this lack of guidance for cannabis substitution at MAP presented just another chance for EIDGE and CMAPS to work together. And the result of those discussions were two brand new resources.
I can say
Yeah. Sure.
2 sentences right now.
Mhm.
I'm on the cannabis program at the CMAP here at the Drinkers Lounge. I've been eating more and I've been sleeping better, despite my hospital stay, but that was an aberration. That was a different thing. And one thing I want to gently remind people about, which I forgot to say earlier, people's material conditions need to change. What's the point of going to detox if you're gonna go to the same shitty SRO or go back live in a tent? If you're lucky enough that a cop didn't steal your tent or a park ranger didn't steal your tent.
Yep.
You know.
Yeah.
One thing I like to remind VANDU and EIDGE is we spend far too much time justifying our substance use without necessarily analyzing why we use substances in the first place. I drink every day because I see people living in tents. I see the cops being violent, and it's just a way for me to forget. That was more than 2 sentences, but yeah.
No,
Mhm.
very good sentences. And so, you know, we like to point back to the cannabis resources as this place where EIDGE and CMAPS knowledge sort of came together to create two effective resources. One that was meant to be client-facing for MAP clients getting cannabis, and one that was meant to guide MAP program staff to dispense cannabis too. So I remember having to put this together, EIDGE convened focus groups. I remember being here on the VANDU patio with 8 to 10 older guys who sort of all since passed, Hank, or not Hank, Miles, Earl, Cecil, for example. And, you know, talking through as illicit drinkers, as folks that do or have used non-beverage alcohol in particular, why do you use cannabis? And those conversations did some fascinating findings, like the ways that that crew of drinkers use cannabis to regulate their appetite, to eat more, to stay well, to manage pain, to manage GI symptoms, for example, to not necessarily do their own withdrawal management, but to cut down, to taper, to ease morning shakes. So those kind of nuances that were only accessible to the EIDGE membership were able to be captured in those discussions. She then brought back to the CMAPS team, to support with safe tapering guidance, with guidance for staff on best practices in motivational interviewing, in, you know, standard joint models at that time. And so thankfully we were able to publish what this process kind of looked like in the International Journal of Drug Policy this past year. So for everybody's interested in reading through this collaboration just as a narrative with the cannabis work as a case study, folks can find it there. And so just to close us out, we just spend a moment talking about a couple of campaigns that EIDGE is working on now, in addition to supporting CMAPS's work. So Herb, can lean on you for these. But, you know, as a peer-governed organization and, you know, as a program coordinator, I take direction from the EIDGE membership. The EIDGE membership and the EIDGE steering committee gets to direct what policy priorities the group works on. At the moment, EIDGE is prioritizing work on MAP member empowerment, thiamine supplementation, and nutritional harm reduction for drinkers, improve equity in acute care at Vancouver St. Paul's Hospital, and to advance cannabis substitution.
And just getting people out of the neighborhood.
It's true. That's a good point.
If you live on the downtown east side long enough, your life literally shrinks to like 8 blocks. That made me lose the thought I was also gonna. Oh, one thing I also want to say is like the houseless people all over so-called Canada, the working poor, the addicted people, the people who are dying from the drug war. These are not bugs of the system, they're features of it. We live in a late stage capitalist settler colonial society, in my analysis and opinion. and they need houseless people to keep the working poor in check. And the police also need the houseless people because they almost get a guaranteed budget increase in every city in so-called Canada. And the police were originally created to move Indigenous people from their traditional homelands.
So, in closing, so EIDGE's primary campaigns at the moment is peer empowerment at the neighborhood's only only currently active MAP site called the PHS Drinkers Lounge CMAPS. So Drinkers Lounge is a bit of an odd MAP model. It's quite unique in the sense that it is a community-led drop-in space that is a non-housing attached brewing co-op in which MAP participants do traditional intakes, but buy in and actively work to run the program's day-to-day operations. It's a U-Brew. The Drinkers Lounge is run and supplied by peer-led beer and wine. That becomes the basis for folks' MAP plans that are enrolled there. Despite the really high degree of peer involvement at the Drinkers Lounge, the EIDGE membership tends to encounter quite familiar tensions between like member preferences and demands and the traditional kind of hiccups of nonprofit leadership in a top-down service model. Therefore, recent campaigns at EIDGE have really focused on sort of elevate a group of peer leaders at the Drinkers Lounge to leadership roles in intake procedures, meeting facilitation, programming, and internal policy change with PHS management. Herb's done a fantastic job doing peer-led programming unsanctioned by the organization to fill gaps perceived by the membership. The point that was previously raised about peer buy-in for restrictions on outside alcohol, we are absolutely seeing that at the Drinkers Lounge. There's some conversations about potentially trying to revisit intake criteria to better match the current needs of the membership too. And so this is something that EIDGE quite actively tries to support. So on a really big vitamin and nutritional harm reduction kick. So drawing unlived experience of certain EIDGE members. Sorry. That's okay. The EIDGE membership began to realize that it's really kind of acute dearth of nutritional focused harm reduction resources out there for folks that were actively drinking, specifically folks that were drinking heavily. So we together as a group, we consulted the academic literature, dietitians, the gray literature, and really tried to figure out if EIDGE were to put together this kind of resource that could be circulated at other MAP sites, what would it emphasize? And really, that we're kind of zeroed in on B1 deficiency as a serious problem amongst most MAP clients, heavy drinkers. This informed his work to both do peer-led B1 supplementation and to advocate for the inclusion of OTC B1 on the BC drug formulary as a psychiatric med or long-term care medication.
And that's all thanks to George, who is cooking some delicious food, I'm pretty sure, just a few blocks away.
Yes, definitely, where we're going to head after. This is also working with Providence Healthcare in BC to build solidarity with frontline care staff. This partnership began about a year ago. The understanding that illicit drinkers and folks that use drugs have consistently bad experiences in these hospital settings. And at the same time, years of austerity, the violence of drug prohibition have put frontline hospital staff in an incredibly precarious position themselves. They're facing burnout too. So with Providence Health and Elizabeth Bishop, EIDGE is currently working to build actual relationships between our drug user group and the Providence Care frontline staff to address these concerns. So in conclusion, the EDGE view is that the relationship with the CMAPS team is built in, quite mutually beneficial, and is really like a natural partnership from the outset. The EDGE membership holds unique, inaccessible knowledge and skills as the CMAPS, and by leveraging this partnership, we get better data, more ethical community-based work, and better advocacy on the EDGE side of things. This kind of mutual support has continued through cannabis work and will hopefully for years to come. And finally, this is just tying back to the member empowerment point here. MAPS are typically incredibly clinical, highly surveilled spaces. We kind of view the work that EDGE does at the Drinkers Lounge site as sort of making the claim that MAP members are agents, not clients. We recommend if folks are running a MAP or looking to start one, that sort of formal, accountable mechanisms for peer leadership be built in and respected, because the program's only successful if it has authentic buy-in from the membership who have the capability to do that. And we think that that's especially important to recognize in these spaces that are typically extremely clinical.
To say that differently, I like to remind our EDGE and our lounge members, yes, we are drinkers, but that doesn't have to define us. We have agency. We just forget about that. Often because we're trying to find the solution to our problems at the end of a bottle. I've drank probably tens of thousands of bottles. The solution is never there. That's why I talk about superstructures and material conditions all the damn time.
So that's all from us. We like to close our presentations with the Rest and Power slides. This is just meant to acknowledge that on the VANDU membership, EDGE has extremely high rates of death due to alcohol related harms, chronic illness, and since 2015, contaminated stimulants also. I would actually be amiss if I didn't end this call or our segment of it with a bit of a call for solidarity with the drug user liberation front right now, with Jeremy Calicum and Eris Nix, who are facing criminalization for doing work that protected EDGE members meaningfully. So if folks get the chance, either in their professional or personal lives, to support DULF, EDGE would appreciate it.